very comprehensive, almost excessively comprehensive introduction. I'm extremely grateful to the scientific and the organizing committees of the ISN for kindly inviting me to present this meeting. It's particularly poignant for me because in 2015 I submitted a paper for verbal presentation at the American Heart Association at their forthcoming meeting then in December 2015. And I didn't hear any response from this submission at all, although many people in my own center had their papers accepted. And I didn't hear, and so I chased the AHA and I said, what's happening with my paper? And after some delay, they accepted it as a poster. I haven't created or stood by a poster myself since the early years of the last century, so this was very disappointing for me. But within 24 hours, I got an email from Kai inviting me to give this lecture. And I said, yes! That's a bit more like it. So I can't thank you enough for rescuing both my mental health and my very non-competitive personality. Well, I wanted to say a word about Claude Amiel as well, because as a junior doctor, I had the pleasure of hearing him speak, and I met him on a couple of occasions. And he was a really wonderful man. You've already heard from Pierre quite a lot about him. I just want to say that all his obituaries were unanimous in saying what a lovely man he was. His outstanding professional and personal high standards were universally regarded, and he was much loved. And it's really an honor and a privilege to give a lecture commemorating him and his name. This is the topic of my talk. And I will give some conflict of interest disclosures in that I am the inventor of some new treatments for systemic amyloidosis, which have been licensed to GlaxoSmithKline and are being developed in collaboration between them, myself, and a company which I set up and in which I'm involved. Now, I am not a nephrologist, but I have got some reasonably respectable renal credentials in that in my junior doctor career, I worked for some really great nephrologists, including Professor Lord Rosenheim, who made great contributions to the treatment of urinary infection, and of course Charles Dent, who will be familiar to all nephrologists, who was one of the most brilliant physician scientists I have had the pleasure and privilege to meet and work for. And actually my first paper, published almost exactly 47 years ago in The Lancet, was a nephrology paper, so I think I have a little bit of renal credibility, even if it's very ancient. Systemic amyloidosis, which is what I'm going to talk about, is a protein misfolding disease, and it's caused by the misfolding of a number of soluble, natively globular plasma proteins, which, having misfolded, aggregate to form abnormal, insoluble amyloid fibrils in the extracellular space of tissues and organs. There are about 30 human proteins that can make amyloid, and they include normal proteins and abnormal proteins. The normal proteins are transthyretin, wild-type transthyretin, which makes amyloid in nearly everybody if you live long enough, so that's just prolonged exposure to the normal concentration. And then there's another type of amyloid called AA amyloid, caused by serum amyloid A protein, a major acute phase protein that is persistently raised in people with chronic inflammation or chronic infections, and that leads to this type of amyloid. And then there are abnormal proteins, where the abnormality can be acquired as part of an underlying primary condition. The most important of that group is AL, so-called AL amyloidosis, caused by monoclonal immunoglobulin light chains produced in monoclonal gammopathy, whether myeloma or MGUS. And this is actually the most common form of systemic amyloid that we normally diagnose and treat. And then there are very rare genetic abnormalities caused by single residue substitutions in a number of different proteins, which make those proteins amyloidogenic. And most common of those is transthyretin, but also there are many others, fibrinogen, lysozyme, ApoA1, and so on. The amyloid fibrils formed by all these different proteins look very similar to each other, regardless of what protein they're formed from. And amyloid deposits are composed of these fibrillar masses, which you can see in the EM here, and also abundant proteoglycans and glycosaminoglycan chains of restricted subtypes. And finally, there's always present a non-fibrillar normal plasma protein, which is serum amyloid P component, which will be a major topic as I go along through this talk. Now, in amyloid, what happens is that the abnormal deposits accumulate, usually inexorably, in the extracellular space. They therefore damage the structure and accordingly the function of whatever tissue or organ they are in. And the big mystery, as yet unsolved in amyloidosis, is why doesn't the body get rid of it? It's made up of autologous proteins, autologous carbohydrates, which the body is normally very, very effective in getting rid of. And yet amyloid is very poorly cleared at all. There's no inflammation around it, no cells infiltrate it. There's no systemic inflammation associated with the presence of amyloid in the tissues. And you only get the disease, clinical disease, when fibrillar amyloid deposits are present. So people can have a predisposing condition like myeloma or a genetic abnormality through decades of their lives without becoming sick until the amyloidogenic protein actually makes amyloid fibers which deposit in the tissues. And the more amyloid there is in the tissues, the more disease, and vice versa. Amyloid can go away, usually very slowly and only partially, in some of the patients if you get rid of the precursor protein. But if it does go away, the clinical situation can improve. Now, I want to exemplify this mystery of amyloid in a very personal medical way. This is a beautiful pair of photographs, I have to say that modestly, of me on the St. Moritz-Korvach Glacier at 3,000 meters on the 6th of March this year, having made some exquisite turns in the lovely soft snow. That was the 6th of March. On the 9th of March, in very poor conditions, I unfortunately fell, and I tore my left hamstring muscle about here, and I bled because I was on low-dose aspirin, 1.5 liters of blood into my leg. This was a very painful and actually, for me, quite dangerous event. So there's 1.5 kilograms of debris, plasma, proteins, blood, cells, in my leg, and 3 weeks later, it's all gone. That's what happens. All of you have had a bruise, it goes away silently, clinically silently. The macrophages are champion garbage collectors. Why don't they get rid of amyloid, which is not nearly as much as this in terms of mass in most patients, sometimes can be more, but the macrophages don't touch it. Now you can see why having amyloid in a vital structure like the glomerulus destroys its function. Here is a patient with afibrinogen amyloidosis, hereditary type, which typically loads the glomeruli up with amyloid. And here you see in strong cross-polarized light after Congo red staining, the pathognomonic green birefringence by which we diagnose amyloid. And the heart, too, you can understand why this heart, which is 3 times the normal mass, cannot pump very well. It's so rigid it can't dilate in diastole in order to pump out a decent stroke volume afterwards. Even though the myocardium is Olympian muscle, it'll keep on contracting, but if it can't dilate, it can't fill with enough blood to retain a normal cardiac output. Here is the heart, the explanted heart of a patient of mine who had a hereditary type of amyloid and had a heart transplant, and this heart is standing up there proud and uncollapsed, unlike a normal heart which would just flop down. This is solid with amyloid. You can diagnose this amyloid very well by cardiac magnetic resonance imaging. He has one modality, late gadolinium enhancement, but you can understand why amyloid destroys the structure and then the function of the tissues. And this enormous expansion of extracellular volume stuffed with amyloid can be measured very precisely now by equilibrium MRI, and you can see that compared to healthy volunteers here, the extracellular volume is virtually doubled in the patients with different types of systemic amyloid in the heart. The treatment, the current treatment of amyloid, and indeed all the existing treatments up till now, have had 2 main goals. One is keep the patients alive. Do what any of you need to do to keep the patients alive, maintain and replace the function of failing organs if you possibly can, long enough to try and reduce successfully the production of the amyloidogenic precursor protein. Sometimes that's possible, often it isn't. More recently, people are focusing and trying to develop means to inhibit misfolding of the precursors so that these precursor proteins can't misfold and then aggregate, and also try to stop them forming the amyloid fibrils. But to my mind, it's obvious that the best thing you could possibly do for a patient with amyloidosis would be to get rid of the amyloid deposits, and that's what we have been trying to achieve. So what do we do in terms of keeping the patients alive? Well, as nephrologists, of course, you're champions at it. You can replace renal function, dialysis, transplantation, and I would say to you as nephrologists, which I'm sure you know, the outcomes of transplantation in systemic amyloidosis are as good as renal transplantation for any other systemic disease. So people in the past used to be put off and say, oh, it's a systemic disease, it'll recur and so on, which is true, but the patients do as well with systemic amyloidosis after renal transplantation as any other systemic disease patients do. And then you have to be rigorous about expert medical management of fluid, drugs, infection, blood pressure, all the things which nephrologists know how to do better than anybody. But the kidney with amyloid in it is exquisitely sensitive to anything going wrong. Drop in blood pressure, a bit of infection and so on, and you just lose glomerular filtration, which may have been preserved for quite a long time. It just suddenly collapses and the patient's going to end-stage renal failure. As far as trying to get rid of the precursor proteins, there's been a huge and wonderful revolution in drugs for myeloma, and these are used for treating AL amyloidosis. So a lot of new drugs, they're very effective, much more effective than they used to be, but they're also very toxic, so it's cytotoxic chemotherapy and pretty challenging to use. Anti-inflammatories, likewise, are vastly more efficient than they were in the past, and actually AA amyloidosis has almost disappeared in the developed world because we're so good at managing inflammatory disease. Antisense oligonucleotides and small interfering RNA are new exploratory methods of trying to reduce production of transthyretin, which is an important amyloid fibril-forming protein. Unfortunately, both those approaches have hit serious problems in the clinical trials, and it's doubtful whether they'll make it all the way to becoming registered drugs. And in the past, we developed, together with colleagues in Sweden, liver transplantation as a form of surgical gene therapy. Get rid of a liver that's making an amyloidogenic protein that's only made in the liver, and give the patient a normal liver that's making the wild-type non-amyloidogenic protein. Unfortunately, this was introduced for transthyretin amyloid, where it doesn't really work very well because wild-type transthyretin is itself amyloidogenic, and so the disease goes on progressing in most patients. But for fibrinogen amyloidosis, you really can get rid of the bad protein and replace it with a normal protein, so liver transplantation should be curative. However, the main target organ of this type of amyloid is in the kidneys, and the risks of liver transplantation are greater than just doing a renal transplant. And when the kidney reaccumulates the amyloid in about 7 to 10 years, you just have to do another one. There are some drugs that are being used, but they're not really effective as ways of trying to stabilize transthyretin, this important protein, and stop it making amyloid. We have invented a new family of drugs which we call superstabilizers, and they're in the early phases of development. I won't say more about them now. But what I am going to talk mainly about is anti-amyloid immunotherapy. I'm an immunologist, and I've hit on a way, I hope, of using antibodies to get rid of amyloid deposits, and we're developing that with GSK. There are 2 other companies that have other antibodies directed specifically at AL amyloidosis, where they are reporting promising clinical results from very early phase trials, but they haven't tried and indeed have not shown any removal of amyloid. And so the case has to be open on whether those are going to progress well or not, but we shall see. Now, why do we need to have these treatments for amyloid? And the answer is it's a terrible disease to have. These show the appalling survival statistics for patients with AL amyloidosis, who are 70% of our patients. If the disease is very early phase and there's no abnormality going on with cardiac markers, they do reasonably well with chemotherapy. Most of the patients in the middle group, survive for a number of years, but the patients with advanced disease die very, very rapidly, within months of diagnosis. It's a really appalling unmet medical need. How do we treat them nowadays? The answer is the proteasome inhibitor drugs, starting with bortezomib, Velcade, and there have been others that have come along since, are remarkably effective, much better than anything that was available before. And there's a large range of second and third line drugs and new drugs coming along, the immunomodulators following on from thalidomide and so on. And various combinations of these chemotherapies can get most patients with AL amyloid into partial or good remissions, clonal remissions, if they can tolerate the drugs. And there's a new antibody coming along, daratumumab, which is anti-CD38. That's an antigen that's present on B-cell, plasma cell lineage, and that looks as if it might be miraculously effective, and it's about to start being used in AL amyloidosis now. So for patients with AL amyloid and low-risk disease, which is about 1/5 of the patients, they can have high-dose melphalan with autologous stem cell transplantation rescue or full-dose chemotherapy, and you'd expect most of them to go into a complete or very good partial remission. 60% of the patients have intermediate-risk disease, and they can sometimes tolerate full or attenuated dose chemo, and some of them will respond. But the high-risk patients, another fifth of the patients, do terribly badly. They die within the first 6 months of diagnosis. It's an unacceptably bad outlook for them, and there's not very much you can do. They don't tolerate the chemo. You can put in an ICD, but they don't always protect against ventricular arrhythmias. Heart transplant for the occasional fortunate patient, or left ventricular assist devices, but not many people are going to get those. So what are we going to do about it? Well, my story starts with serum amyloid P component. This is a normal plasma glycoprotein. It's a member of the pentraxin protein family. It's a minor constituent of all human amyloid deposits, and I've been working with this lovely protein since 1974. Here are the first electron microscope pictures which enabled us to identify what the protein was, and here is its crystal structure that we solved a number of years ago. Now, in the 70s, I showed that the reason why SAP was present in all amyloid deposits is because it's a ligand-binding protein. It wants to bind to amyloid fibrils. And later we showed that all the SAP in amyloid deposits comes from the SAP in the blood. It's only made in the liver, it's in the blood, and it gets from the blood to wherever it's going to go, which is in this case amyloid. And because of this binding to amyloid, there's something like a 20,000-fold specific concentration of SAP over other plasma proteins in amyloid deposits. And that led me in the 80s to the invention of SAP scintigraphy, where we radio-label purified human SAP, inject it intravenously into the patient, and then image the patient in the gamma camera and see where has the SAP gone. And the SAP equilibrates between a small pool of soluble SAP in the plasma and the extracellular fluid, perhaps 100 milligrams of it altogether, and the very much larger amount of SAP in the amyloid-associated pool, which can be up to 20 grams. And this imaging technique gives fantastically helpful images. Here you can see a patient with AL amyloidosis. Amyloid deposits are present throughout the bone marrow, where the plasma cells are that are making the immunoglobulin chains that make the amyloid, and also in the hugely expanded liver and spleen. And here a completely different distribution, seen from the back in this case, a patient with rheumatoid arthritis who's got amyloid in the spleen, in the kidneys, and here you can see amyloid in the adrenal gland. A remarkably useful thing to be able to do. This is another patient with rheumatoid arthritis who had proteinuria. If you remember one thing from this talk, nephrologists, any patient, any adult patient with proteinuria, you must think of amyloidosis. You must not forget to think of amyloidosis. So this patient had a scan, and it was normal. There's no amyloid there. But a year later, another scan, because she continued to have proteinuria, shows massive amyloid in the spleen and in the kidneys. So after 20 years of rheumatoid arthritis, she developed amyloid. And here's another pair of patients. These are two AL patients. They were exactly the same clinically, couldn't distinguish them, but the scan showed this patient had amyloid only in the kidneys. This patient's got massive amyloid in the liver and in the spleen. Now, these were both candidates for high-dose melphalan and stem cell transplantation. This patient would probably have done quite well with that treatment. This patient would almost certainly have died. And at the time this was done, the procedure mortality for that treatment was about 50%. We've got a lot better at doing it than... Ooh, I've lost my pictures. Now they've come back. Gone again. Okay. We've got a lot better at stem cell transplantation now. We select the patients very much more carefully, and the procedure mortality is now about 5%. That's through patient selection and better experience. And here's another very important discovery that the scans gave, that amyloid can go away. So this is the two patients in whom we got rid of the amyloid fibril precursor protein, and you can see over a couple of years amyloid is cleared substantially from the liver and rather a lot from the spleen. And here another one with the liver clearing most but still less in the spleen. So amyloid can regress. This gives us a lot of encouragement. As a result of the scanning, we became the de facto national referral centre for amyloidosis patients in the UK, and after 22 years of my unit at the Royal Postgraduate Medical School, I moved to UCL, to the Royal Free Campus, and the Department of Health in the UK then funded us as a single specialist centre for the whole country. They pay all the expenses for all the patients and all the medical services that we deliver. I appointed Philip Hawkins, who had been my PhD student when we were inventing the scan, as the clinical director. We were seeing 300 patients a year in 1999. We now see over 4,000 patients a year. There are 70 people who run this center, doctors, nurses, everything else that you need to run this service. We do over 1,200 SAP scans per year, which we consider essential. And I commend to you these two websites. Anybody who wants clinical advice and management advice about amyloidosis can contact the clinicians in the National Amyloidosis Center. And patients and even doctors can learn a lot from our patient information website, which is a fully interactive, comprehensive website, everything anybody would want to know about every type of amyloidosis. Now, over the years, I grew more and more convinced that SAP wasn't just a useful tool for diagnosis, but was also a player in the pathogenesis of this disease. The fact that it's universally present in amyloid deposits, which was discovered before I was in the field, way back in the 60s, tells you it's either something to do with the disease or it's some amazing epiphenomenon. But I went on to show that SAP binds to all amyloid fibril types, that the SAP in amyloid is not degraded, that SAP is highly protease resistant, and when it binds to amyloid fibrils, it protects them from degradation. What we want the macrophages to do is come along and eat up the amyloid fibrils, but they have no receptors for SAP on their surface. They don't see SAP as anything abnormal, and if they did see and want to eat it, it resists them because it's very protease resistant and it stabilizes the fibrils. And others showed that SAP also promotes amyloid fibril formation. And finally, we made SAP knockout mice, and although they get amyloid when you try to induce amyloidosis in them, they get less of it and get it more slowly than wild-type mice. So that confirms that SAP is a valid therapeutic target. Now, I'd had that idea even some years, many years before. We published a paper in The Lancet when we first discovered a defined chemical ligand for SAP. And this ligand, a small sugar, which you can see here, if you homogenize an amyloidotic organ with a sufficient concentration of that sugar, all the SAP floats out. So I suggested this could be, turn that into a drug or something like it. That could be a way of separating the components of amyloid and leading to amyloid clearance. And eventually, in the 1990s, I persuaded Roche in Basel to collaborate on a drug discovery program to make just such a compound. I invented a high-throughput screen for the sort of test that we wanted to find, the sort of compound we wanted to find. They screened 100,000 compounds, they got a lead, and they made a drug. And this is the drug which Pierre mentioned at the beginning, which I named CPHPC. It's a palindromic acronym. It's because this compound is actually carboxy, pyrrolidine, hexanoyl pyrrolidine carboxylate, so CPHPC. It's a palindromic molecule and a palindromic name, and actually just lately it's got its WHO international non-proprietary name, which is miridisap, so henceforth and through the rest of this talk that's what I'm going to call it. And what this drug turned out to do wasn't quite what we wanted. We wanted it to remove all the SAP from amyloid deposits, and it turns out, as I'll show you, that it can't quite do that. But what it does do is it forms a stable complex between two SAP molecules, which you see here, each of which is pentameric, and 5 drug molecules. And the 5 drug molecules cross-link the 2 protein molecules, and the body sees that as abnormal and clears away the SAP from the blood. And here's the crystal structure of 1 drug molecule cross-linking 2 of the protein molecules. And when we infused the drug for the first time into patients, to our astonishment, the SAP just disappeared from the circulation. I'm trying to get my pointer to come close enough, but I can't. Okay, well, you can see in the figure on the left that the SAP concentration falls. And if you keep patients on this drug for as long as you wish, can we try and get this freed up a bit so I can use the pointer? If you keep patients on the drug, SAP remains suppressed compared to what it was before you started treating them. Where does the SAP go? And the answer is the liver. On the left here, you can see this is a patient with a modest amount of amyloid in the body. They've had some radiolabeled SAP, and it's in the circulation, in the heart, and you can see it in the main blood vessels throughout the body. And from the back, you can see that there's amyloid in the spleen and in the kidneys. And within 6 hours of giving our drug, the appearance has completely changed. There's now, if you can see the one that's called anterior at 6 hours, there's no radioactivity, no SAP left in the blood, in the heart. It's all in the liver. And the amount of SAP that's left in the amyloid in the spleen is much reduced. So a clinical study went on. Patients had the, thank you. The patients had the drug for a couple of years, and the most important thing that we found that it was completely safe, no adverse effects at all. And the SAP in the plasma was depleted throughout. But because there's such a lot of amyloid and the SAP binds to it so avidly, not all the SAP is removed from the amyloid. And therefore, disappointingly, although most patients remained clinically stable, no amyloid regression was observed. So this was, in a sense, a failure of what we had set out to achieve. So I spent some time thinking about this and realized that we could use this failure to our great advantage. We can use the Myridisap to deplete circulating SAP, but leaving some SAP in amyloid deposits, uniquely in amyloid deposits. We can then safely give anti-SAP antibody to target that residual SAP in the amyloid. Now, you couldn't do that without the Myridisap depletion, first of all, because if you inject an antibody against an abundant plasma protein, you will form immune complexes, and as nephrologists, you all know, you will then get glomerulonephritis and systemic vasculitis and kill your patient. So not a clever thing to do. But by depleting the plasma protein first, we can safely give the antibody. And I chose the antibody specifically to bind to the SAP in the amyloid, to trigger complement activation on the deposits, to attract the macrophages, opsonize the amyloid so that the macrophages would then destroy it. And that is what happened. So we gave mice amyloid, and they're stuffed with it. And then we gave some of them a control neutral IgG, and others got the anti-SAP antibody. And these are human SAP transgenic mice, so they're making SAP just like humans, human SAP. We give them the Myridisap to deplete the circulating SAP, and then we give them this one antibody shot. 28 days later, the control animals have got their spleens still completely replaced by this green staining amyloid. The antibody-treated ones, hardly anything left, maybe a tiny speck here or here, almost all gone, absolutely miraculous. We wrote this up some years later when the patents had all been filed, and here I can show you the histology of how it works. This is before any antibody is given. The pink stuff in this is the liver, of course. This is the pink stuff here is the amyloid deposits. The most important thing to see is that there are no inflammatory cells showing any interest in them at all. That's the mystery of amyloid. One day after putting in the anti-SAP antibody, however, every bit of amyloid is surrounded by mononuclear cells, macrophages, surrounded. Within 5 days, these macrophages have fused to form multinucleated giant cells, surrounding, engulfing, and destroying the amyloid. And 2 weeks later, it's all gone. Normal histology. No amyloid, no cells, no damage, no mice died, nothing bad happened to them. The amyloid just went away. And here you see it at the EM level. Before treatment, all the amyloid is, as it always is, extracellular, outside the cells, in the spleen and in the liver. After this treatment, the amyloid is all inside the cytoplasm of these massive multinucleated giant cells. And here you see another example of that. So this is 1 to 2 days post-antibody, lots of amyloid in the spleen. Here is a multinucleated cell just forming adjacent to an amyloid deposit. Here is a multinucleated giant cell taking, figuratively speaking, a big bite of amyloid fibrils into its jaws. 3 to 4 days later, much less amyloid. All the amyloid is inside the cytoplasm of these multinucleated cells, as you can see here in a phagolysosome being digested. And it turns out that these multinucleated giant cells have an exquisitely adapted phenotype for doing just this job. In collaboration with a very good group in Germany, we published recently a description of the phenotype of the multinucleated giant cells, which we created in vitro. So they're derived by macrophage fusion. There is abundant extraplasma membrane formed by the fusion of all these many cells together into one cell. And these ruffles of extraplasma membrane bear on their surface pre-activated complement receptors and down-regulated FC receptors. They want to eat some things that have got complement on them. And they are super for surrounding and internalizing large complement opsonized objects in vitro, just as they do in our model in vivo. So what we have now is not a combination therapy, but an obligate therapeutic partnership. You can't have one without the other. Myridisap alone doesn't promote amyloid regression. The anti-SAP antibody, which has now got its proper name, which is desamizumab, cannot be administered without prior and continuing depletion of the circulating SAP by the Myridisap. So this SAP depletion uniquely enables anti-SAP antibodies to trigger complement-mediated removal of amyloid deposits by macrophage-derived giant cells. We licensed this invention to GSK in February 2009. They fully humanized the antibody for therapy. They took our best mouse monoclonal anti-human SAP antibody and made it a human antibody. They've done the phase 1 studies with the miridisapalone followed by desamizumab. It's generally well tolerated in the patients so far. There's no doubt that it removes amyloid in patients just like it does in mice, and furthermore organ function gets better. And the latest thing is that we've given it to half a dozen patients with cardiac amyloid, and they've tolerated it very well. And the phase 2 trial, specifically in cardiac amyloidosis, is just starting now. This report was published in the New England Journal of the first part of that phase 1 study in 2015. Here is a couple of examples from it. This is the first patient in whom we observed this therapeutic effect. So this is a patient with moderate liver, a large spleen, small bone marrow and kidney loads of amyloid. He had 246 milligrams of the antibody after SAP depletion. You can see that all patients in whom the treatment is efficacious get an acute phase response of CRP and SAA. They consume complement, C3 falls, several grams of CO3 are consumed. Doesn't seem to upset the patients at all. And 42 days later, amyloid has disappeared from the liver and is reduced in the spleen in this patient. And the extracellular volume of the liver has shrunk from 37% of the liver, much too big, down towards normal, which is 29%. The liver stiffness, which was way over the top, 14.4 kilopascals, has gone back towards normal. Here is another patient. Once again, you can see a massive load of amyloid in the liver. 6 days later, essentially all gone. Much reduced uptake of SAP into the organ, reduced extracellular volume, reduced liver stiffness. And now in the second part of the phase 1, we gave repeated doses and larger doses. And some patients didn't respond to the first dose we gave them, but they did respond to the second or the third. It's a question of getting the right dose relationship between antibody and the amount of amyloid and the amount of SAP on the amyloid. And you can see here progressive removal of amyloid from the liver with repeat dosing. And this is before and after the first dose, before and after the second dose. So really substantial clearance of amyloid. And the pharmacokinetics of the antibody correspond to this. So when the first dose is given, there's a certain peak and then a very rapid fall of antibody as it clears and sticks to the SAP and the amyloid. After you've got rid of a lot of amyloid in the same patients, giving the same dose again goes to a much higher peak concentration and then a much slower clearance because there's less target of SAP and less amyloid for it to attach to. And things get better. So as I've said before, ECV gets better, extracellular volume, liver stiffness gets better, liver enzymes get better, gamma-glutamyl transpeptidase, and you can see here many examples of reduction in the abnormal liver function tests. So getting rid of amyloid is good for organ function. We've measured it in the liver. We haven't, which is easy to measure, of course. We have not followed it long enough in the kidney to see reduction in proteinuria yet, but we anticipate that that will happen because there's no doubt that this treatment does remove amyloid from the kidneys as well as the liver and the spleen. You can see here an example of a patient with a hereditary type of amyloid in the spleen and in the kidneys before and much reduced afterwards. So drug development is proceeding. We've got orphan drug designation for this in both Europe and in the US. The phase 1 trial, as I've told you, is completed. The phase 2 trial focused on cardiac amyloidosis is starting right now as we speak. And so in conclusion, anti-SAP immunotherapy with these two new drugs, miridisap and desamizumab, it's applicable to all forms of systemic amyloidosis. It doesn't matter which protein is making the amyloid fibrils because SAP is our target and that's the same in everybody. Removal of SAP will improve clinical status. And the question is, will it increase the efficacy of interventions to reduce amyloid formation? We hope to be able to keep the patients with advanced amyloidosis alive long enough with this treatment so they can respond to the chemotherapy or whatever they need to get rid of the precursor proteins. And we believe the treatment has encouraging potential to improve outcomes and prolong survival. I would like to acknowledge the many years of continuous support for my research from the Medical Research Council in the UK, and latterly, and now going off into the future, from the National Institute for Health Research, from the Wellcome Trust, the Wolfson Foundation, BHF, and the US NIH. We have donors to our research fund who are extremely generous and help us a lot. We couldn't do any of this without the patients and the families, of course, and I have had many collaborators and colleagues over the years, and now, of course, I'm grateful to GSK for taking this on in a big way. Before I finish, I want to say one other thing, which once again, if you don't remember anything else, please remember this. We have to diagnose amyloidosis before we can treat it, before any of this therapeutic progress can happen. So all nephrologists, I believe, would be well advised to think of amyloid with every patient, an adult patient who has proteinuria, especially if they have any signs or symptoms of disease elsewhere in the body, because amyloid is systemic. So any of these things should alert you. Think amyloidosis. Then you need to do subcutaneous fat biopsy. That's the least invasive. A rectal biopsy, and obviously a renal biopsy. It has to be stained properly with alkaline alcoholic Congo red according to the method of Puchtler. Very easy to do, but a lot of people don't do it properly, and you get the answer wrong if you don't do the stain properly. You have to observe it in strong cross-polarized light in order to get the right answer. Obviously, there should be a Congo red stain on all adult renal biopsies, regardless of what you think the diagnosis might be, because you might miss amyloid. And if it's Congo red positive and amyloid is there, you need an amyloid specialist to do the amyloid typing, because the treatment is completely different if it's AL, AA, hereditary, and so on. And you need management advice. Multi-system expertise in amyloid is really important for the best outcomes for these patients. Thank you very much.
Thank you very much, Mark, for this superb lecture of translational medicine, which provides a lot of hope for the patients affected with this devastating disease. And now I will give you the certificate on behalf of the International Society of Nephrology.